Thank the organizing committee for inviting me to speak, as well as dedicating the first session of this excellent conference on head and neck sarcomas. So I've been tasked to talk about the role of systemic therapies in head and neck sarcomas, and Dr. Chow as well as Dr. Chan has given you very good overviews, both in terms of radiation-induced sarcomas as well as the pathology. And I would now like to move on to talk about systemic therapies and whether or not I actually have a role, or whether or not I need to hold that little sign and say that I'm actually part and parcel of patients actually developing sarcomas. So these are my disclosures. So I think to begin with, just a brief background about head and neck sarcomas. Dr. Chan has already told you that these are relatively rare entities, and it accounts for about 2% of all head and neck malignancies in adults and 4 to 10% of all sarcomas. Approximately 30% of head and neck sarcomas occur in children, and the majority of being rhabdomyosarcomas. When it comes to adults, in actual fact, there are different subtypes, and radiation-induced sarcoma certainly is something that we do encounter quite a lot of because of our NPC prevalence. In terms of median age of diagnosis of all head and neck sarcomas, we're really talking about the fit and young group, 50 to about 59 years of age. And actually, most series do report a slight male predominance over females. And actually, when we talk about head and neck sarcomas, we're really talking about a large variety of locations, given the fact that any region within the head and neck has connective tissue, which is ubiquitous. And head and neck sarcomas being coined as one entity is certainly a misnomer. On the pie chart on the left, you could certainly tell that there are a large variety of different histological types. And Dr. Chan has already told you that they do behave differently. And certainly when we talk about the locations as well, it can be very varying, essentially from the scalp all the way down to the bottom of the neck. So actually with these two combinations of varying histologies and varying locations, we are really talking about varying prognoses as well as varying approaches in terms of treatments. And I think to begin with, I'm a medical oncologist and I handle sarcomas as well as thoracic malignancies. And granted that most of the sarcoma patients do not have the diseases in head and neck, my question always is, how are head and neck sarcomas different from head and neck tumors as well as sarcomas of other sites? So let's compare head and neck sarcomas with other head and neck tumors first. And certainly in most instances, the sarcoma histology is less chemo and radiation sensitive compared with, say, head and neck squamous cell carcinoma or NPC. The other point is certainly surgery remains the mainstay of treatment for head and neck sarcomas. And of course, this would be different from NPC, where it is radiation together with chemotherapy. And I think Dr. Chow has elegantly already told you that most of the time, in terms of post-radiation sarcomas, they occur infield to the previous malignancy. So therefore, we essentially have a very limited potential treatment option, given the fact that a lot of the regions have already been radiated, and therefore all the organs at risk have already reached max dose radiation. Typically, these are relatively aggressive, and generally also patients after the first malignancy going on to their second one have a poorer performance status and makes any other treatment more difficult and more risky. When we compare this with other sarcomas of other regions, the biggest problem is you can't have a wide resection margin unless you want to do a decapitation, and that's not compatible with life. And in terms of role of adjunctive treatments, be it radiation and chemo, it is actually less defined as opposed to some of the larger series. We've talked about the organs at risk. And overall, one of the issues, of course, is we don't have a large population. Therefore, we don't have a large amalgamation of evidence. And therefore, we don't really have the data to support some of our approaches. Local recurrences is actually more common in terms of failure of secondary malignancies in the head and neck. And again, because of the locality, you have limited salvage options in the instances of local recurrence as well as relapse. Now, talking about systemic therapies, and I think to begin with, we want to talk about systemic therapies for two scenarios. One would be for the patients who have inoperable or metastatic head and neck sarcomas. And in general, that's actually quite straightforward because the way we would treat these patients is just as how we would treat sarcomas of other bodily regions. And what we do know is that systemic therapies in this situation is well established, and the treatment approach is very similar to other sarcomas of other regions. And there have been advances over the last 10 to 20 years in terms of the fact that we have better drugs. We have histology-based treatment approaches in the second-line setting. And after all, we have smarter oncologists compared to before. And this slide here on the right-hand side is actually quite interesting. And for us who may not be too involved in sarcoma management, what you can see here are the advances in terms of clinical trials and their results phase 3 studies of patients with advanced soft tissue sarcomas throughout the years. And if you look at the different boxes, what you can see in 2014, and that was the landmark study using our gold standard drug doxorubicin together with doxorubicin plus ifosfamide, what you can see is that the median overall survival of those patients with the doxorubicin arm was 12.8 months. Now, fast forward to 2019, so that's only about 5 years down the line. In another clinical trial where the control arm, doxorubicin, again is being used at the same dose through the same setting, the median overall survival of these patients has actually improved from 12.8 months to 19.7 months without changing the way we treat our patients in terms of drugs. So that's mainly because of the fact that for all our patients, because of the fact that sarcoma is recognized as a distinct entity, we have better supportive care for these patients. We have better second-line treatment options for these patients. We've recognized the fact that, as well as Dr. Chan has mentioned, that sarcoma is a heterogeneous, and we may be treating it differently between the different patients. And overall, we have specialist centers such as ourselves here, where we have an MDT approach to our treatment. So I think what I'm really trying to hammer home is the fact that all is not lost for our patients with advanced head and neck sarcomas. Certainly, it's a difficult situation, but we do have therapies available. And sometimes it's not only the drug, but it's the holistic approach of how we care for our patients. Now, going back to other situations of sarcomas where we're talking about, say, the operable patients, where we're considering either giving adjuvant or maybe even neoadjuvant approaches. I think to begin with, in terms of sarcomas overall, and not just the head and neck, what we do know is that adjuvant chemotherapy is really not going to benefit everyone. And currently, the evidence is based on clinical trials and meta-analyses on extremity sarcomas, which have previously been histology agnostic. And the older clinical trials actually, in terms of prior studies, used drugs which were really not optimal. Subsequent meta-analyses have actually shown the role that the use of our doublet chemotherapy of doxorubicin and ifosfamide in combination has been able to improve overall survival in patients who are considered high-risk soft tissue sarcomas. Now, the current consensus in terms of extremities sarcomas, and I would also like to then draw the comparison to our head and neck situation, is in situations where patients have good performance status, limited comorbid factors, the disease location, tumor size, as well as histological subtype, all really come into consideration as to whether or not we should consider giving adjuvant chemotherapy to these patients. Of course, most of these patients are relatively young in the primes of their lives, and we also need to discuss in terms of the possible toxicities, possible sterilization because of the chemotherapy, other potential issues, including the risk of cardiomyopathy, renal damages, as well as secondary malignancies, of which Dr. Chow has mentioned. Quality of life is also very important as well. And in general, for patients with extremity sarcomas, which are deep-seated, larger than 5 centimeters in size, high grade, and of histologies which are sensitive to chemotherapy, we do recommend the use of using chemotherapy as an adjuvant or potentially neoadjuvant. And our standard approach is to use doxorubicin and ifosfamide. Now, there are some practical advantages, though, of pushing this chemotherapy from adjuvant to a neoadjuvant setting before the definitive surgery. Because, of course, it is quick to start. It's much easier for me to start chemo than for you to book an OT slot and see the anesthetist. All I need essentially are the baseline bloods, making sure the cardiac function is okay. We would like to have a central line, but sometimes we can't, and we're good to really start the chemotherapy. And if there is actually evidence of response, we're able to see some quick improvement in symptoms. And in general, I think before surgery, patients' performance status is better and therefore, again, more tolerable to chemotherapy. And giving the chemotherapy first instead of post-op, there is less of a risk of affecting wound healing or causing wound dehiscence. There are other theoretical sort of biological advantages of using neoadjuvant approaches. Of course, to begin with, if you have some sort of cytoreduction before your surgery, you're able to control the symptoms, as well as possibly less radical surgical resection is necessary. Is early indication of effectiveness of treatments. The vascular supply is not compromised prior to surgery or radiation, and certainly we need a good vasculature to ensure we're delivering the chemotherapy. And in situations where patients are at high risk of developing distant metastases, you have an immediate control of the micrometastases on hand. Now, our practice generally for extremities sarcomas as well as other sarcomas, is most importantly a multidisciplinary discussion. Biopsies are mandatory if technically feasible. And as mentioned previously, in situations where there are high risk, we would consider neoadjuvant chemotherapy. And also situations where they're uncertain or suspicious of possibly having distant metastases, or if there is possibility of multifocal disease, we will give upfront chemotherapy. And our choice of chemotherapy generally is quite standard, although in some histologies, such as leiomyosarcomas, we may change it around just because of the fact that we know that they are more sensitive to particular chemotherapies. I think most importantly, in terms of a neoadjuvant approach, is the response rates of these patients, we're talking about 20 to 30%. So there are and there will be patients who may progress throughout the chemotherapy phase. And what's most important is we are able to monitor them closely with regular imaging, such that if there are situations of disease progression, we are able to stop the treatment and then move on to the next modality, which most likely would be surgery. Now, I talked a bit about extremity sarcomas, and it's really because there's not much evidence for head and neck sarcomas. What I'm now going to now try to do is compare some of the factors that we use to decide for adjuvant or neoadjuvant chemo in extremity sarcoma with head and neck situations. So I mentioned the fact that typically we look at size, location, grade, and whether or not there are sensitive histologies. And on your table here is actually showing the situations where we would give neoadjuvant or adjuvant chemo in extremities. And this is what is common in the head and neck setting. I think to begin with, in terms of size, larger and equal to 5 centimeters, well, not quite. I guess typically in the head and neck region, I mean, sometimes they're not that sizable, but then they're already quite easily recognized. But in terms of location, they're quite deep sometimes within the nasal cavity. The grade really depends on the type of tumor that you have. And in terms of sensitive histologies, actually, some of these are actually quite commonly found in the head and neck sarcomas as well. So I think there is some role to consider using neoadjuvant approaches in terms of chemotherapy for head and neck sarcomas. But I think it is controversial, and we do need to bring it to the MDT to decide. And how is the situation different in terms of head and neck sarcomas versus extremities? Actually, Dr. Chow has already mentioned to you the fact that in general, it is very difficult to get a good margin, and the margins, even of a good resection, is going to be tight. The ability to give high dose adjuvant radiation will be difficult, especially in situations which is a post-RT sarcoma. And size per size, same histology and grade. If you compare the same tumor in the head and neck region versus the extremities, what we do know is that in actual fact, these patients do more poorly. And in general, they're just less fit in terms of performance status. And what we also want to achieve for the benefit of our surgeons as well as for our patient is we are actually more insistent in trying to get a response and shrinkage of these tumors as opposed to just keeping stability, because of course, having a smaller tumor would be good for subsequent treatments. But yeah, exactly. So we want to make sure that we can facilitate radiation as well as surgery. Now, talking about specific sarcoma histologies in the head and neck region, what are the histologies that we're actually referring to? I have a picture of an alphabet soup because it is actually quite difficult to really understand all the acronyms and all the short forms that we have. Again, Dr. Chan has shown you some of the data from our own institution. This is actually a series published from the Memorial Sloan Kettering Cancer Center in New York, where they amalgamated over 300 cases of head and neck sarcomas over a 30-year period. And essentially what you can see is that the most common histologies includes undifferentiated pleomorphic sarcoma, dermatofibrosarcoma protuberans, angiosarcomas, SFTs, desmoid fibromatosis, and the list goes on and on. And I think it's important to note that all these actually have very different behaviors and different sensitivities to treatment. Now, the knowledge of these different histologies are extremely relevant because we know that they have differing biological behavior. There are different propensities to whether or not they will have distant metastases or whether or not they'll have local invasion. The tempo of disease will be different as well. And of course, there's also an importance of surgical margins. Now, for example, we know that for DFSP, the way the tumors grow is actually they grow like with multiple digits. So you do need a wide margin. But in situations of desmoid fibromatosis, what we've proven is that intralesional excisions are probably just as good as having a wide margin in terms of survival for our patients. We also need to know the fact that they have different sensitivities to systemic therapies. And that, of course, has an impact on whether or not adjuvant or neoadjuvant therapies do work for these patients, whether or not there are cytotoxics or targeted therapies suitable in such a situation as DFSP, as well as the role of checkpoint inhibitors and other immunotherapies. And this is just a quick graph, just showing you the fact that there are different sensitivity to cytotoxics. In situations where the mainstay of treatment is a key chemotherapy component, such as Ewing sarcoma or rhabdomyosarcoma, there's no doubt that systemic therapy is extremely important. Having said that, the run-of-the-mill head and neck sarcomas are in the yellow group, where we think that there may be a potential role of neoadjuvant chemo. There are also some situations where we know that chemotherapy is unlikely to be useful, like epithelioid sarcoma. But having said that, in situations such as solitary fibrous tumor, DFSP, or even alveolar soft part sarcoma, we have emerging evidence of new targeted therapies or immunotherapies available in the metastatic setting. And certainly in situations like this, we would like to consider employing them in the upfront setting if it means that it's going to be a better surgery and better outcome. So one last example, and I know I'm running out of time. I just want to take a quick view and take you through some of the drug developments that we've done for head and neck sarcomas. And specifically is a rare type of sarcoma in the head and neck region, but I'm sure you would have seen one or maybe two before. And these are angiosarcomas. And typically they affect the cutaneous regions of elderly patients in the head and neck region or the scalp. It could also be post-radiation, and that's typically in breast cancer patients who have received radiation therapy to the chest wall. Actually, this type of sarcoma is more common in Asians as opposed to the West, and it accounts for about 7% of all sarcomas. And this diagram here, these pictures on the right, are the patients that you would see. Now, the treatment approach for cutaneous angiosarcoma typically is multimodality with surgical resection plus or minus radiation in resectable situations. The problem, though, is it's very difficult to achieve a good margin for these patients, and local recurrence is extremely common. Biggest issue, of course, is these patients are elderly, they have comorbidities, and in the advanced or metastatic disease setting, we do consider palliative chemotherapy. The choice of chemotherapy is the taxane group, including paclitaxel, and there have been increasing use of taxanes over the years, but this drug is also associated with peripheral neuropathy. Some people have infusional reactions, and there's a need to give steroids as a pre-medication. And with all these patients who are elderly and having diabetes, it becomes problematic as well. Now, there's a new drug that we've been involved in its development as well as clinical trial known as Oraxel, which is essentially an oral form of paclitaxel. Traditionally, oral paclitaxel cannot be absorbed because within your GI tract, you have these P-glycoprotein pump inhibitors, which pumps out the drugs and you're unable to absorb it. But with combination of this P-GP inhibitor, in actual fact, it allows the absorption of this paclitaxel. And what you can see in actual fact is a very good pharmacokinetic profile where on the blue line is the oral paclitaxel, where you see the peak concentration is not very high, but there's a long area under the curve, which allows for a good essentially absorption and effect of the drug. And this is just some pictures to really end my talk, showing you the fact that in situations such as this 93-year-old patient who actually has a scalp angiosarcoma, serially, you are able to see quite a good response in terms of the oral paclitaxel. And this is actually another patient, 75-year-old lady, extensive disease, which was deemed inoperable, but again, able to take oral paclitaxel with some response as well. Most importantly, this is also another patient from our Taiwan colleagues within the same trial. Again, you could see very good responses as well over a period of time. And also patients are able to tolerate the drug for a long duration as well. These were just the results that we actually handed into the FDA about a week ago. And what you can see is just to impress upon you the waterfall plot, seeing that most of the patients who were able to take this drug had a very good response. And most of the patients are elderly as well, with the oldest one being our patient who was 93 years of age. And what also is important is the fact that if you look at the waterfall plot, the stars are the patients who were initially deemed inoperable, placed into the trial, had a very good response, and then went on to have surgery. So there is a potential for cure of these patients when given Oraxel. So in conclusion, I would just like to end by saying that head and neck sarcomas are rare conditions, and it encompasses a mixed group of tumors with varying biologies. I think the main issue is the anatomical location, which actually limits a wide margin. Certainly, we are reliant on improvement in outcomes of radiation therapy as well as systemic therapies in this situation. We have to know the natural history of this particular disease and the disease that we have on hand, and we do need a multidisciplinary team approach. And with the advancements of what we have, including cytotoxics, targeted therapies, and immunotherapies, we hopefully have been able to improve our patients' outcomes. I'd like to thank you very much for your attention, and we could certainly discuss a bit more during the panel discussion. I apologize for going over time. Thank you very much.
Thank you. Thank you.